It's great to be with you today. I wish I was in Alaska with you, but sadly, I'm talking to you from Houston, Texas. So let's get started. I'm going to spend the next 20 minutes talking about ovarian cancer prevention and some of the studies that we've recently completed. I have no financial disclosures. So the two topics that I'm going to go over today, first, how we really tried to increase accessibility to genetic testing using an online platform, which is different than kind of the classic way that we recommend pre-test genetic counseling in person and then testing, and then again in-person post-test genetic counseling. And then we're going to talk secondly about a strategy for prevention in high-risk women that we really think is patient-centered, that we've partnered with the advocacy group to really consider, and that's taking out the fallopian tubes first and delaying oophorectomy, and that's a study called WISP. So I just want to talk a little bit about the revolution in hereditary cancer genetic testing. And maybe the most important thing is that from a big picture perspective, the majority of ovarian cancer is not inherited. So we think now that 20%, maybe up to 25% is due to individuals or women inheriting from their dad or their mom a mutation in a gene that puts them at increased risk for ovarian cancer. But that means that 80% of women with ovarian cancer do not have an inherited predisposition. So this talk is going to be focused on those individuals that do have a gene change that caused their ovarian cancer. And in the early 1900s, we knew that that there were families for which there was more cancer than we would expect. But it wasn't until the 1990s that we identified specifically which genes could be passed from parent to child that would increase risk for cancer, and that would explain why we see these families with more cancer. And that was the discovery of BRCA1 and BRCA2. And then in around 2010, two important things happened. One, there was the first FDA approval for PARP inhibitors for BRCA-associated tumors. That was a huge breakthrough, not just for women with inherited ovarian cancer, but also individuals that had BRCA mutations due to non-inherited causes, as well as other molecular defects in the homologous recombination deficiency pathway. And then I would say more recently, in the past couple of years, we've seen incredible increased access to genetic testing through commercial labs in which the cost has dramatically lowered. And all that has happened and really changed the landscape of our opportunity for prevention and screening. So just going over several major advances. One, the understanding that about 20% of ovarian cancer is inherited, and women with certain genetic mutations are at increased risk of developing ovarian cancer. The second, I talked about PARP inhibitors, and you're going to hear a lot more about PARP inhibitors from other talks. Third, the dramatic decrease in the cost of genetic testing. And finally, understanding the origin of ovarian cancer. And we know that for BRCA-associated ovarian cancer, as well as probably for the majority of high-grade serous ovarian cancers, it really starts in the fallopian tube. And how knowing that it starts in the fallopian tube actually gives us opportunity for thinking of novel prevention strategies. So you've all heard of BRCA1 and BRCA2. This just reminds me to tell you that they're big genes, that mutations can occur anywhere along the genes themselves, and that these germline mutations dramatically increase the risk of not just ovarian cancer, but of breast cancer as well. And this is a study that Liz Swisher's group published in 2011. And it basically took a group of 360 women with ovarian cancer. And of those 360, about 17.8% had a BRCA1 or 2 mutation. And another 6.4% had a gene mutation in these other genes. And I call these sometimes alphabet soup because there's so many different genes. But in each of these, it was only one to 4 individuals that had these gene mutations. So in total, in this total group of 360 ovarian cancer patients, about 23.6% had inherited a germline mutation that might have increased their risk for ovarian cancer. And this is a classic pedigree, and you can see the black arrow and where it says BRCA1, that's an ovarian cancer patient. And that patient now in 2020 would be treated differently than if she had developed ovarian cancer in 2000 because of PARP inhibitors. And that information that she inherited a BRCA1 mutation is important for her and for her treatment of ovarian cancer, but it's also incredibly important for her relatives. And look at the next generation, where her children each have a 50% chance of having the BRCA1 mutation, and they don't have cancer. So they can intervene so that they don't develop ovarian cancer and screen for breast cancer as well. And her nieces have a 25% chance of inheriting that mutation. So when they do genetic testing, that becomes powerful information for them to intervene before cancer develops. And this slide just talks about the convergence of treatment and prevention. And it kind of shows, just reinforces, I think, that that drop of water, that's the patient with cancer herself. And when we identify a mutation, and remember, it's about 20% of the time we'll identify a mutation, all of her family members, and I kind of view that as all the rings that that spread out from that drop of water, can take that information and undergo preventive strategies and prevent cancer. This next slide just shows the dramatic decrease in the cost of DNA sequencing from 2001 to the present. And this has been such a huge game changer. Genetic testing used to be about $4,000 for 2 genes, and now it's about $250 for many, many more genes. And that dramatic decrease of sequencing has allowed us to really increase access to genetic testing. But there remain barriers. And even though we test every woman with ovarian cancer for BRCA because it has such an important implication for the patient's treatment. And by having that information, all the relatives should be able to test, but there remains barriers to this concept of cascade testing. Sometimes there's barriers from family communication. It's a burden to the patient. Sometimes the family members don't want to hear about it. Some individuals still find it costly. Some individuals may not have access to good genetic counseling and genetic testing. So all these are barriers that we were thinking about how can we address this. What if I could do genetic testing from my living room? And that was really the basis for the Magenta trial, that you didn't have to go to a doctor or go to a clinic visit. It could be done anywhere in the United States. You'd have access to good genetic counseling by phone, but do everything online. And so the question really is it feasible? Does it result in more distress and less knowledge? And that was the genesis of the Magenta study, which stands for Making Genetic Testing Accessible. It was funded by Stand Up to Cancer. We were all part of the ovarian cancer dream team and really appreciative of the funding. So the Magenta study was asking, can we deliver genetic testing to women in their homes? And also, how much genetic counseling is optimal? Does it need to be the classic way where you have in-person pre-test counseling and then post-test counseling? Can some of this information be delivered online? So the goal of Magenta is to compare a standard approach to genetic counseling, and we consider a standard approach to be telephone counseling for both pre and post genetic testing, to 3 alternative approaches. And this is a prospective study. And the next slide shows the different arms. This was a 4-arm non-inferiority study. And you can see that arm C was the control arm. That's where you had someone talk to you by phone beforehand to give you pre-test education. And also after the results, they would be delivered by someone by phone as well. And arms A, B, and D looked at different variations of the theme. And arm A was really saying, what about if we just give everything online, both pre-test and post-test, and you would just get your results and you wouldn't even have to talk to anyone by phone. As support, we said that if anyone tested positive, we would require them to talk to someone by phone. The next slide just shows the website. We actually had a video that described the study, and then you could click and fill out an eligibility questionnaire. So the eligibility criteria was that you had a family history of breast or ovarian cancer. You can see here what the eligibility criteria was. The next slide kind of just shows how you did it. You would fill out your eligibility questionnaire, sign consent, fill out your baseline questionnaires. You'd have a spit kit sent to you, spit in a tube, send that back, and then your results would be available in a couple of weeks. We did a 19 gene panel, and again, all positives were required to have post-test counseling, and all women at any point had access to phone counseling if they wanted. And just quickly to show you, this is a screenshot of what the online consent looked like. The next slide shows that we used actually social media to enroll the majority of our patients. The next slide shows the questionnaires that we sent out. Our primary outcome was looking at cancer risk distress at 3 months after testing, but we also looked at some quality of life, depression, decisional regret questions. And I love this slide. It's a picture of the US, and I'm realizing now that we don't have the picture of Alaska, so I'll have to change that. But we had women from every state enroll in this study, and so proud of that. On the next slide, you can see the genetic test results, and you can see that the study identified individuals that had mutations in lots of different genes. Specifically for BRCA1 and BRCA2, we found that 1% of the family history cohort and 5% of the cascade cohort had mutations in BRCA1 and BRCA2. And other important genes were identified that increased risk to ovarian cancer, such as RAD51C and RAD51D. And we look at our primary outcome, which was distress at 3 months. The bottom line was that each of the 3 experimental arms was non-inferior to our control arm at 3 months. And this really showed that this was a safe way of delivering the information. Our next steps for this study is to really understand further barriers. We really did not have as much success in terms of minority recruitment or in rural communities, and just showing that we are starting in Texas a study based on our Magenta results. The word previvor, I'm not sure if you've heard of that before. This was the Time Magazine top 10 buzzword in 2007, so a long time ago. But it basically means a person who doesn't have cancer, but who has a genetic predisposition to develop the disease, or a pre-survivor. And we know now that there's a growing number of these women who now know that they're at increased risk for breast and ovarian cancer. So we have to do something in terms of talking about management. And so what do we recommend? Well, we don't have great screening, and we always tell women that screening with either ultrasound or a blood test called CA-125 has never been shown to decrease death from ovarian cancer. So we are very careful to not have them feel falsely reassured. And what remains the cornerstone is surgical removal of the ovaries and fallopian tubes, which is not easy. For BRCA1, the recommendation is by age 40, and for BRCA2, it's by age 45. And even with hormone replacement, that early menopause impacts quality of life. So I'm going to talk about our second study, WISP, which looked at the new information that ovarian cancer associated with BRCA1 and BRCA2 actually starts in the fallopian tube, and proposes that maybe we can actually take out the fallopian tubes first and delay removing the ovaries. And we really see this and have worked with our advocacy groups to test it. This is just showing that when we look very carefully at the fallopian tubes and the ovaries of individuals that have BRCA mutations, that you can find microscopic cancers. And this next slide shows that when we do the surgery, actually one of the most important parts is the pathologist, where they cut the ovary and the fallopian tube in 2 to 3 millimeters, and they look very, very carefully and actually can find microscopic cancers. I'm going to skip this next one but it shows basically how ovarian cancer, oftentimes we only see it until it's really late. So it looks like it's on the ovary and it's a big glob. But if you could kind of get an early insight into the development of ovarian cancer, we think that it actually starts in the fallopian tube. Sometimes it drips down into the ovary. The ovary is this nice, warm environment full of nutrients, and it can grow there. We don't think all ovarian cancers start in the fallopian tube, but we think the majority do. And so there's a rationale for thinking about salpingectomy first and delaying oophorectomy. The clinical idea is that it's going to improve side effects associated with removing the ovaries. There have been studies that we've conducted, surveys that showed that these BRCA previvors really, really wanted to study this as a prevention option. So the next slide shows where the study was conducted. It was conducted actually in 9 sites throughout the US. It was non-randomized, so women could choose either to have their ovaries and fallopian tubes removed or just their fallopian tubes and delaying their ovary being removed. And this just shows that there's 2 different groups. There's the group that had the salpingectomy and could delay oophorectomy, and also the group that had risk-reducing salpingo oophorectomy. This big red stop sign in the middle showed that we had safety stopping rules. So if we found that women were developing cancers after they had had their salpingectomy, the study would be stopped. And the next slide just shows the methods. We did a lot of questionnaires that looked primarily at sexual function. That is the complaint that high-risk women tell us that even with hormone replacement, they really struggle with. And so we wanted to measure that as our primary endpoint. We also looked at menopausal symptoms, as well as cancer risk distress and decision regret. And I'm not going to talk through kind of the demographics, but in general, these women were in their late 30s and 40s. Most were well educated, and the majority have had BRCA1 and BRCA2 mutations. Just to let you know, in the ISDO or in the salpingectomy arm, we didn't identify any cancers at initial surgery or importantly after salpingectomy, so our safety stopping rule was not triggered. In our RRSO arm, we did have a case of a stick, and actually this was in a PALB2 carrier. So PALB2 is one of the newer genes that's been identified and associated with ovarian cancer. And we believe this is the first identification of a stick in a PALB2 carrier. In terms of symptoms, just very quickly, as you would expect, there were fewer issues with hot flashes in individuals that had the salpingectomy. Vaginal dryness, same thing. Weight gain, same thing. And we are currently evaluating the data and preparing the manuscript. But I wanted to kind of just jump right to the summary because this showed that the results that we had in our study, but also there was a very large Dutch study. And these were numbers that were from about a year ago, but we had, at the end of the day, 300 women, high-risk women. The Dutch study had over 500 women. So together it was 900 high-risk women who were enrolled in a study of salpingectomy versus risk-reducing salpingo oophorectomy. And if we look at this together, there was decreased cancer worry in both groups. There was fewer menopausal symptoms in the salpingectomy arm. There was improved quality of life that was seen in both studies. The sexual function is being studied in both groups. The safety stopping rule was not enacted either in our study or the Dutch study. Even though it's too early to say that this is a reasonable way to prevent ovarian cancer in high-risk women, so that cancer efficacy endpoint isn't quite there. We still believe that we should go to the next step and really plan that international trial to study a larger number. It'll probably take about 3,000 women to enroll in the next study. So in summary, wanted to just say that there is a genetic testing model with online delivery of pre and post-test counseling with telephone support for those who test positive as needed. And this really was non-inferior to the standard of care. This is ongoing now in multiple commercial labs and is available to the public. As cost decreases, we're going to see more and more people undergoing genetic testing for cancer and other diseases. And so we're going to have to come up with a patient-centered strategy for both prevention and early detection. And so our study, our WISP study, tested that novel prevention study of salpingectomy and delayed oophorectomy. And we found that there were improvements in quality of life and menopausal symptoms and sexual function compared to risk-reducing salpingo oophorectomy. There wasn't any kind of obvious safety issues. And so we really believe it should proceed to be tested for efficacy. So I've reached my time and really appreciate your listening, and I'm happy to participate in the panel and answer any questions. Thank you so much.
Hi, I am Dr. Rachel Masch, and I am an associate professor at the Icahn School of Medicine at Mount Sinai, and I am also the Chief Medical Officer of Basic Health International, which is a nonprofit group with a mission to eliminate cervical cancer globally. And it is wearing that hat today that I'm going to speak to you about novel screening and treatment of cervical precancer experiences from around the world. Here are my financial disclosures and my objectives. I'd like to review worldwide cervical cancer statistics and then talk to you about the current screening tests and treatments that are available, discuss their limitations, and then talk to you about some alternatives that are under investigation. So first, the problem. This is from 2018, and in 2018, there were 570,000 new cases of cervical cancer per year. And of those, more than half, 311,000 women die every year. And most of that burden is shouldered by low and middle income countries. The cervical cancer is completely preventable. More than 99%, almost 100% of cervical cancer is caused by the human papillomavirus, HPV, for which we have a vaccine and ways to detect the precancerous forms early before it becomes a deadly disease. Unfortunately, there are many disparities because cervical cancer really is a disease of lack of access. And here are some headlines from our own country that show the disparities in care around cervical cancer. And the disparities are not just racial, but also socioeconomic, and it leads to many, many women not having access to life-saving vaccinations, screenings, and treatments. In Alaska, the rate of cervical cancer is slightly higher than the rate in the overall United States, although the mortality is about the same. However, there are disparities that exist in Alaska too, whereas Alaskan Native women have a higher incidence of cervical cancer, 11.0 to 7.1. And of those women, they are often diagnosed at a later stage and are twice as likely to die from cervical cancer than their white counterparts. So let me discuss with you cervical cancer and just briefly how it works. Here's a pyramid that shows a normal cervix at the bottom. And when a normal cervix is exposed to HPV, there are changes that happen to that cervix, and you can identify these changes. If those changes persist, in the next 3 to 4 years, about 15% of women will go on to have low-grade disease, or CIN1, cervical intraepithelial neoplasia 1. And of those women with CIN1, about 30 to 70% of them in the next 10 years will then go on to have a higher grade precancer. All of this, however, is before it reaches invasive cervical cancer. And the area from the green below is where we can screen and treat women and halt the progression of the disease. The goals of BHI and the research that we do is to develop patient-centered, comfortable, affordable, and accessible screening and treatment options for women around the world, but particularly those who live in low resource and remote settings. So let's talk about how we do that. And that is, we tend to focus on secondary prevention. So not vaccination, but how to screen and treat. So I've put together a list of what I would consider things that are necessary for a perfect screening test. And that would be that it would have to be inexpensive, easy to perform by any level of provider, and preferably by the woman herself. That is called self-sampling or self-collection. And although that is not yet FDA approved in the United States, it is approved in other areas of the world. It should also be a point of care test so that you would be able to make a diagnosis in real time. My example for this is like a urine pregnancy test where you pee on a stick and then within the next few minutes, so almost immediately, either a positive or a negative sign comes up, indicating that you either are or are not pregnant. That is a true point of care test because you can then know almost immediately and then start acting upon that information. A perfect screening test should also be accurate and have high reproducibility. So let's talk about what screening tests are available now. And this is the list. I'm going to start with the first, the Pap smear, also known as cytology. And I think most of us are familiar with this test. The Pap smear requires that you go to your provider, you assume the position, and then you have a speculum exam placed in the vagina. The cervix is identified and cells are taken from both the outside of the cervix and from inside the cervix, and these are sent to a lab for analysis. So the limitations of the Pap smear are that the sample needs to be a good sample. It needs to be put in the right collection vial or media. It needs to be processed correctly by the laboratory once it gets there, and it needs to be read correctly by the pathologist or the cytologist. It also requires many visits. So when you have a Pap smear, you then go home, you wait for the results of the Pap smear. If it is abnormal, you get called back for another diagnostic test called a colposcopy. The colposcopy typically has biopsies that are taken, which then get sent to the lab. You have to wait for that diagnosis. And if those are also positive, you then have to come back for a treatment. This multiple visit approach is really not feasible in many places around the world. So how can we do better? Well, let's just talk about the Pap smear in terms of my list. So it is not difficult to perform, and it does have good accuracy if it's done frequently and high reproducibility when the pathologists are reading it correctly. However, because of the multiple visit approach and all of the things that are necessary to make it happen, it is not inexpensive. It cannot be done by the woman herself. And as I discussed, it is far from a point of care test. So what else do we have? There's something called visual inspection with acetic acid, and that's called VIA. Acetic acid is white vinegar, and we have found that white vinegar applied to the cervix can bring out changes that indicate that it has been affected by HPV. So the way this works is that you go see a provider, they do a speculum exam, identify the cervix, and then take a large Q-tip dipped in white vinegar, acetic acid, and place it on the cervix for 1 minute. After that time, you look at the cervix and see if you note any of the changes that are consistent with an HPV infection. You can see here at the bottom on the left is a negative cervix, and on the right, there's a thick white plaque that is called acetowhite changes that is consistent with HPV exposure. So VIA is very inexpensive. You can buy gallons and gallons of white vinegar for not very much money. And it is easy to perform by all level of providers. The caveat to that is that once they are trained, it is easy to perform, but they do need to be trained and there do need to be frequent quality assurance visits, and those can be costly. This cannot be done by the woman herself, but indeed this is a point of care test because you are able, after 1 minute to 3 minutes of looking, are able to make a diagnosis in real time. However, it is not that accurate and does not have very good reproducibility. And we tend, because there are changes that happen that don't necessarily mean that a woman is going to go on to have cervical cancer, we tend to overtreat based on VIA. So the next step that has been developed has been testing for the very thing that causes cervical cancer, human papillomavirus. And these are the HPV tests. HPV is a large family, and just like any large family, there are individuals within that family. These individuals are called subtypes when we're talking about HPV. And there are 14 subtypes of HPV that cause cervical cancer, and some are more likely to cause cancer than others. So HPV tests are able to identify if a high-risk HPV variant is present in the specimen. There are many places now that are considering using HPV testing by itself without a pap smear, and this will make it much less expensive, more scalable, or able to be used in large populations, and actually is more accurate than the pap smear alone. So the HPV test actually meets many of the perfect screening test criteria. Right now, in the past, historically, it has been quite expensive, but now there are some less costly alternatives. It is easy to perform by all levels of providers and also can be self-collected by the woman. It is not currently a point of care test, although there are some tests under investigation that have a very quick turnaround time, and it does have good accuracy and high reproducibility. So the HPV test in concert with that is something called HPV genotyping. And whereas this is not truly a screening test, it is a triage test, but it can help us to identify the which high risk types are actually present. So we know that the highest risk types for cervical cancer are HPV 16 and 18. Those cause 70% of cervical cancer globally. And those are the ones that we should certainly not let go, that need to have treatment as long as there's no evidence of invasive cancer. But these HPV genotyping tests can test for the specific subtypes. We can identify those that are most likely to cause cancer and then treat those women who are at highest risk. According to my perfect list, this thus far is not inexpensive, but we're working on that. But it is easy to perform by any level of provider and by the woman herself. And there are, although it's not point of care yet, there are some tests under investigation that do have a very quick turnaround time. And again, it is very accurate and has high reproducibility. Lastly, I want to talk to you about another screening test, and that involves artificial intelligence and algorithm-driven image diagnosis. And the way this works, and it is experimental, so I just want you to be aware of that, is that a provider performs a speculum exam, identifies the cervix, applies acetic acid, the white vinegar, and after 1 minute, takes a picture of the cervix using a smartphone. On that smartphone, we're hoping that there will soon be an app that image gets compared to an archive of images that have biopsy-proven diagnoses, and it gets run through the AI, the artificial intelligence algorithm, and a diagnosis can be returned within seconds. This screening modality is inexpensive once the equipment is purchased, and there is an app, as I mentioned, that is being did on any smartphone. It is easy to perform by all level of providers. It is a point of care test, so it can make a diagnosis in real time and has very good accuracy and high reproducibility. This is an area of active investigation, so stay tuned. Okay, so the woman has been screened and she's positive. What now? Well, she must have access to treatment. Treatment of cervical precancer can halt disease progression and save lives. So we cannot screen women unless we can offer them treatment. The question is, how can women in low resource and remote settings gain access to these potentially life-saving treatments? Well, just like I made a list of my perfect treatments my perfect screening test list, this is my perfect treatment for precancer list. So it, again, needs to be easy to perform by all level of providers, should be well tolerated by patients, should have few long-term complications, should be able to effectively treat disease, and be able to be performed in remote settings, which means that it should be easy to transport and not rely on consumables, meaning things that have to be purchased repeatedly. And that includes electricity, which is really not available in many remote settings. In addition to all of these things, it should also be inexpensive. So here are the treatment recommendations by the World Health Organization. And they are broken into surgery and ablation. Surgery is LEAP and cold knife cone, which I will describe in a few seconds. And ablation is either cryotherapy, which freezes the abnormal tissue, or thermal ablation, which heats the tissue. So a LEAP is an acronym for loop electroexcision procedure. And that is where a highly trained provider inserts a speculum. They identify the cervix, numb the cervix, and then use an instrument with a thin wire loop that's attached to electricity to remove the affected areas of the cervix. A cold knife cone is very similar, except instead of using a wire loop with electricity, it utilizes a scalpel. So these are well tolerated because most of the women either have anesthesia or local analgesia, and they are very effective. However, it does require a highly trained provider, and it does have some long-term complications in regards to pregnancy particularly, and it cannot be performed in remote settings. So it's not easy to transport. It does rely on consumables, including electricity, and it tends to be very expensive. Cryotherapy is where you freeze the affected tissue. And that is my colleague Julio from El Salvador, who is demonstrating that the gas, the tanks of gas that are required for cryotherapy are quite heavy. They can weigh 50 to 70 kilograms. And this 5-foot tank can only treat about 10 to 20 patients per tank. So when we have large treatment delegations, we need several of these tanks. The gas inside of them is expensive and often difficult to procure. And then the tank needs maintenance, storage, and when we transfer it, because it's gas under pressure, it can potentially be quite dangerous. So if I put this cryogen gas cryotherapy to my list, it is easy to perform, it's well tolerated, there are few long-term complications, it is effective, and can be performed in remote settings, although it is not so easy to transport. It does not rely on electricity, which is good, but it does rely on other consumables, which can be expensive. So this is getting there, but not quite. So in response to the gas issue, the cryopen was developed, which is another form of cryotherapy, but one that does not rely on cryogen gas. Instead, it uses a state-of-the-art cooling technology. It is more portable. It weighs about 25 pounds and comes in different iterations, either this round version that's pictured here on the slide, or one that has that's in the form of a rectangular toolbox with a handle. It either can get plugged into the wall to get the rod cooled, or it can be charged with a car battery. It's also easy to use and to clean and is equally well tolerated by patients. So it meets almost all of the criteria on my list. It does require electricity unless you are charging it with a car battery. In addition to these two ablation therapies, there is another one called thermal ablation. And the World Health Organization in 2019 put out guidelines for the use of thermal ablation for cervical precancer lesions. So here's an example of the desktop version of thermal ablation, which has been used since the 1970s, mostly in the United Kingdom. Other names for it are thermocoagulation, thermal ablation. It is heat that blisters the cervical tissue and allows the abnormal tissue to be destroyed. It is very effective with high cure rates. But this obviously cannot be transported so easily into low and middle income countries. We have worked with a German engineering company to develop the YSAP C3 device that is pictured here on the left. This is a portable version of the thermal ablator, and it weighs less than 2 pounds and is easily placed in a backpack and transported to almost anywhere. Some considerations are that we so far don't have any evidence of true efficacy. So that is, I'm going to describe a research project that we're doing to address that. There are also a few side effects, although in some early data that we have, some patients do report higher pain during the actual procedure than they do with cryotherapy, but that pain quickly dissipates once the treatment is finished. It also could either be plugged in or utilize, and in this case, an external battery. The other two devices have internal batteries, but with this external battery, one can do 100 treatments before that battery needs to be recharged. Some challenges that we have with thermal ablation that we're trying to address with a research project that is going on in China, El Salvador, and Colombia is that we don't have a head-to-head comparison of the efficacy of thermal ablation versus standard cryotherapy using the cryogen gas versus the cryopen. So we're getting data on that by taking biopsies 1 year after a woman is treated with one of those modalities. Thermal ablation, we also don't know what temperature is the best temperature to use. Currently, we think it's 100 degrees Celsius. We also don't know how long to apply the heat for and what specific technique. So we're doing a different project to try and answer these questions. We also want to confirm that it's acceptable to patients and to providers. So again, the goals of Basic Health and their research is to develop patient-centered, comfortable, affordable, and accessible screening and treatment options for women around the world, particularly those in low resource and remote settings. Our vision is to live in a world where no woman dies of cervical cancer, which is an entirely preventable disease. I always like to end with a cartoon. So this is the one I will share with you. It is a battery speaking to its therapist with its head in its hands, and it says, "I just try to focus on the positive side of things." Thank you so much for your attention, and I'd be happy to take any questions.
Hi, my name is Dr. Joanie Mayer-Hope. I'm a gynecologic oncologist in Anchorage, Alaska, and it's my pleasure to be speaking to you today about ending racism in women's healthcare, a pathway to saving lives.
Hi, I'm Dr. Florencia Greer. I'm the Chief of General Obstetrics and Gynecology at Penn Medicine in Philadelphia. It's a pleasure to be here with you today.
We recognize that this is a vastly important and enormous topic that cannot be comprehensively addressed in 20 minutes. Therefore, we are going to approach this talk from the heart, more like a TED Talk, a dialogue between two colleagues and friends, one Black, one white, one OBGYN, one GYN oncologist. For starters, I'd like to set the context. Race is a social construct deeply embedded in the field of medicine. Race has no intrinsic biologic basis. It is an inexact proxy for a constellation of socioeconomic, cultural, and genetic factors. Racism is a societal systemic inequality on the basis of this social construct. Racism was woven into the history of this country and permeates all of our institutions, including healthcare today. The historical racist atrocities in women's health are vast and horrifying, the cumulative impact being wide-sweeping inferior health outcomes for women of color across all avenues of women's health today, including gynecologic cancer. Black and brown patients have higher rates of developing and dying from cancer, increased exposure to cancer risk factors leading to disproportionate disease burdens, greater likelihood of having cancer diagnosed at late stage, higher rates of surgical complications and mortality after cancer surgery, and lower enrollment in clinical trials. In endometrial cancer, Black women have a 55% higher 5-year mortality risk than white women. In ovarian cancer, the 5-year survival for white women has improved between 1975 and 2016, while it has gotten worse for Black women. In cervical cancer, the incidence and mortality in Alaska Native women is twice that compared to white women. And during the corona pandemic, Black women with gynecologic cancer and COVID-19 are more likely to require hospitalization and die. The case is easy to make. If we could end racism in women's health, we could save an enormous number of lives. But how do we approach such an enormous problem?
We hope that by sharing our life stories as a foundation for this discussion of racism will be a start. I am a Black woman, a fourth-generation college graduate who was born into a family where education was the priority. My great-grandfather graduated from college during Reconstruction, an era most known for land ownership by free Blacks and the passage of the 13th, 14th, and 15th Amendments. My great-grandmother graduated from college almost 50 years later. They are pictured here in the top left. My grandparents were both educators who taught in segregated schools. They too were college graduates, seen here in the top right. My father was a revolutionary of his own right. He integrated Miami Central High School, enduring numerous indignities in the hopes of access to a quality education. He graduated from Lowell Institute of Technology in Massachusetts and is seen here at his 50th college reunion last year. Education and racism have been interwoven in my family for generations. Because of this legacy, I learned the names of colleges, especially the Ivy Leagues, before I knew the state capitals. There was never a question as to whether or not I would attend college. The only question was simply, which college? The first visitation trip that I remember was visiting Yale University when I was 6 years old. We knew no one who attended the school, so we just parked and walked through the campus. My mom, also a college graduate, felt like this trip was lost on her young daughters who were not in the college frame of mind, as evidenced by our impression of the Gothic buildings with the song, "Yale is a jail and we don't want to go there." My dad retorted with, "White people take their kids to visit colleges this early." This laser focus on education, specifically acquiring the best education possible, was the primary focus of my parents, and their educational foundation is a large part of the reason why I'm here today, a graduate of Harvard University and the University of Pennsylvania School of Medicine. I grew up with the understanding that education was the great equalizer, and I could achieve anything because I stood on the shoulders of giants. I do not take for granted that this legacy of education is the reason for much of my success. I talk about racism and equity as an understanding of privilege. It is my opinion that the way to understand systemic racism is first to understand and own one's own privilege. The privileged have to be willing to relinquish their power for a more equitable society. Intersectionality is often described in relation to the big factors like race, gender, and sexuality. I prefer to look at intersectionality from a more in-depth perspective, where we assess the many categorizations that affect our place in the world, such as classism and education. By examining all the areas in which I am in the dominant categories, I can see that my place in the world is more determined by my privilege than by the categories in which I am considered oppressed, like female and Black. Meaning my education and status in the upper class have directly led to many of the opportunities that I have been given. I know that similar to many white people, I started this race called life more than a few paces ahead of others. I understand and I own that privilege, and thus my priorities are on increasing educational opportunities for those who don't share my background. Understanding one's privilege allows us to look around the table and ask, who's not represented and whose voice is not being heard? And hopefully that introspection will lead to some effort to work to increase equity and improve access. By now, hopefully everyone is comfortable with the term white privilege and understands its origins in systemic racism. For those of you who are still unsure, you can look no further than the white privilege that was exhibited at the Capitol building on January 6th. The core of white supremacy was on full display. Every Black person, and luckily many non-Black people too, saw whiteness exposed and understood that if those protesters had been there for a Black Lives Matter event, the outcome would have been far different. I challenge all of you to do the tough work of understanding the minority experience. It is time for white people to do the work. Commit to doing your part to ending all forms of systemic racism, of which healthcare inequality is only one. I have listed the books which I have read in my book clubs in the last 6 months as a place to get you started.
I am a white woman committed to ending racism. I was born to a middle-class family and lived in Boulder, Colorado until I was 18. My father is a Holocaust survivor born in Hitler's Germany and brought safely to the United States by his parents through several miraculous tricks of fate. My mother is a melange of Unitarian and Quaker, English and Scottish origins. She can trace her family back to the American Revolution. Until my 20s, I'd always believed my mother's side of the family came from the North. As a child, I heard many stories about the abolitionist efforts of my great-great-grandfather. However, in probing deeper, I discovered that he was from a slave-owning family in Tennessee, whose abolitionism emanated from the cruel treatment of slaves in his own home. As a child, my understanding of racism was limited to intense dinner table discussions in Boulder, a predominantly white upper-middle-class town. It wasn't until I attended college at Stanford University and San Francisco State that my political convictions and practical experiences about racism began to merge. Formative were the interracial relationships I was developing, campus racial tensions and activism, and 2 years spent working for Angela Davis as her research and personal assistant. I emerged from college with a deep belief in and commitment to my responsibility as a white person to end racism. I also understood that comprehensive societal change would only come through meaningful, real, and enduring relationships across difference. At 25, I went to graduate school in intercultural relations, where I intensely studied the strategies and barriers to anti-racist white efforts to confront racism in white settings. I'd like to briefly touch on 2 points from this work and from my own journey. Mistakes are an inevitable part of maintaining an anti-racist consciousness in a racist society. By mistake, I mean unintentional manifestations of racism by intentionally anti-racist white people. Maintaining the continual awareness of my racism is like having a quiescent disease. If I take the necessary precautions, I'm usually asymptomatic, but sometimes when I'm especially tired, preoccupied, or try something new, or worse yet, do nothing unusual at all, I make a racist mistake. Once awareness dawns that we can unknowingly be racist as white people, we may start to consciously filter out words and thoughts through a racism lens before expressing them in order to lessen the chance of making blatant racist mistakes. However, too much caution can also be a mistake. Silence can become complicity. As white people develop our anti-racist consciousness, we must be able to find an internal balance between filtering and risk-taking, learning to recover from mistakes and continuing to take chances. When I observe a racist microaggression in my own world, I often experience a dual dialogue in my head. First, I think about my responsibility to the people of color impacted. Second, I consider my responsibility to create some form of transformation in the white person in question. The first notion frequently makes me want to distance from the source, to forcefully refute the comment or act, shut the person up, or strike out in order to establish my anti-racism in the face of her racism, so that our shared skin color could in no way be associated with shared beliefs. The second line of thought, that of creating transformation, necessitates a very different attitude. Rather than distancing, I must get close to the white person in question, understand her motivations enough to approach her in a way that provokes introspection, not defensiveness. This conflict between the desire to distance and the need to get closer represents a complicated and central dynamic in intervening in microaggressions. Our individual interventions are only the first step. Racism is about power. So is anti-racism. Transformative educational practices must be linked to organized structural changes in order to break down the institutionalization of racism. Ending racism can feel monumental and completely overwhelming, like being a drop of water next to the ocean. This is why at age 30, I went to medical school. While seeing the ocean, I chose a lake in which to swim. I decided to become a change agent, a doctor, in a defined system, healthcare, that housed all of the social justice issues, such as racism, that I cared so deeply about.
The medical system is a prime example of racism in that there are enormous racial disparities that exist in gynecology, gynecologic oncology, and obstetrical care. The United States has the highest maternal mortality rate among developed countries in the Western world. Data confirms significantly higher pregnancy-related mortality ratios among Black and American Indian and Alaskan Native women. As of 2017, there were 17.3 maternal deaths per 100,000 live births, a drastic increase from 7.2 deaths in 1987. According to the CDC data from 2014 to 2017 exhibited here, per 100,000 live births, there were 41 deaths among Black women, 28 deaths among Indigenous women, 13 deaths among Asian women, and 11 deaths among Hispanic or Latinx women, in comparison to 13 deaths among white women. It is imperative to note that Indigenous women have over twice the maternal mortality of white women, and Black women have over 3 times the maternal mortality of white women. While socioeconomic status and education predictably correlate with health outcomes, research shows that the higher risk faced by Black women's maternal outcomes spans every income and education level. In fact, a well-educated Black woman living in the wealthiest neighborhoods is still more likely to die than a white, Hispanic, or Asian woman who has not graduated from high school. So what can we attribute this to? Clearly, college-educated women likely can afford good prenatal care. The answer is a complex one, and the solutions to decreasing our country's maternal mortality, and specifically the disparities between white and non-white women, are even more complex. There is an expanding body of research surrounding chronic stress around being a Black woman and the toll that it takes on childbirth. Imagine that the accumulation of just being who you are in this country can lead to poor outcomes. There is, of course, implicit bias in how this plays out, with Black women being labeled difficult patients, receiving less pain medicine, and being less seen frequently by nurses. Research has documented that Black Americans are systemically undertreated for pain relative to white Americans. Indeed, research has shown that Black patients are undertreated for pain not only relative to white patients, but relative to World Health Organization guidelines. Recent studies aimed at identifying the rationale show that beliefs about biological differences between Blacks and whites, like Blacks have thicker skin than whites, can lead to these disparities in how treatment plays out. This is important because these providers don't perceive themselves as racist. They simply believe falsehoods that have been propagated in medicine since the time of slavery. Education, or rather miseducation, still permeates the medical field today. If you question the legitimacy of these studies, check out the recent death of Dr. Susan Moore, a family medicine physician who documented her harrowing experience with COVID-19 in an Indiana hospital on Facebook Live. Even after her death, the CEO of the hospital defended the hospital's position using coded language stating that the nursing staff treated her for coronavirus may have been intimidated by a knowledgeable patient who was using social media to voice her concerns and critique the care they were delivering. A lack of diversification in faculty members across AAMC medical schools can be exhibited here. Despite representing 13% of the population, Black people represent less than 3% of all faculty members at, again, accredited medical schools, not including HBCUs or medical schools in Puerto Rico. But when you look at professors and associate professors, the highest level able to be achieved at an accredited medical school, every racial group except for white is drastically decreased. Fang et al. Looked at 50,000 attendings at different hospitals, and Nunez Smith looked at 100,000 and recognized that despite controlling for NIH funding, for research, there are still disparities in being able to progress from an assistant professor to an associate professor. There are still differences in compensation, and there is still discrimination.
Gynecologic oncology literature almost universally addresses race and not racism as a factor in worse outcomes for women of color. Yet healthcare delivery can be radically different for women of color, even though the diseases are the same. To explain the racial healthcare disparities through the lens of systemic racism requires that clinicians recognize we contribute directly to the problem. So what about the room where it happens? How does racism play out in my practice of gynecologic oncology? How does unconscious bias impact how thorough I am during an extremely difficult surgery? Whom I refer to clinical trials, for whom I request second opinions, how innovative I am in treatment strategies and in my efforts to help my patients be partners and advocates in their own care. The most effective patient-doctor relationships require tremendous trust in the setting of inherent power imbalance. My patients must trust that their doctor has the medical knowledge and unquestionable commitment to be their guide through their life-threatening and complicated cancer journey. So I ask myself, do I create a sense of genuine safety and trust with my patients of color? And if not, how can I overcome that? What about the building where it happens? Alaska Women's Cancer Care. Are we an anti-racist organization? While our staff are from diverse backgrounds, all of our doctors are white. That said, we advocate ferociously for all of our patients. We have express anti-discrimination policies and a zero tolerance for racist behavior. We proactively screen and hire our staff around these principles. Our providers are blinded to insurance status and billing history. We provide care to all comers regardless of their capacity to pay. Could we do better? Yes, always. And what about the system where it happens? What about Alaska Native Medical Center? ANMC is an impressive example of a single payer system built and led by the people it serves. ANMC incorporates cultural competency into every level of care. Healthcare is universally available to tribal members, and the entire system prioritizes leadership by and employment of Alaska Native people with the express, beautiful, and overarching goal of becoming the healthiest people on earth. It is a tremendous inspiration and honor to work within this system for me. That said, as a result of historical racist atrocities, the ANMC system has institutionalized processes that can at times preclude delivery of state-of-the-art cancer care. For example, there are virtually no clinical trials. Structural roadblocks exist to obtaining second opinions, and every genetic tumor testing request requires multidisciplinary tumor board approval. As cancer treatment becomes increasingly linked to genetically driven targets, the importance of overcoming these structural barriers to care becomes ever more paramount. The same protections established to prevent the replay of past horrifying racist practices now inadvertently recreate systemic disparities in cancer care delivery. So what do we do? How do we navigate this? Here are some thoughts to consider. Strategies to ending racism in women's health. Creative advocacy. I try to use my position of power where I can, both on the individual and systemic levels. For each patient and every patient, I advocate tirelessly for her care. It's imperative that we as providers thoroughly understand the healthcare delivery systems we are navigating so we can find the less obvious avenues to achieving outstanding care, while in the meantime, always working towards slow, thoughtful systemic improvements. Working in multicultural alliances. Ending racism in women's health must involve anti-racist white people and people of color proactively working together in solidarity, united by a common goal, that of delivering equal and outstanding healthcare to all women within health institutions that support and reflect this commitment at every level. The power of relationships. The power of relationships cannot be underestimated. Change is born from deep friendships that transcend our many intersectionalities, that hold our complexities, that allow for mistakes, that build trust across difference, that make us feel less alone in our journeys as we fight hard battles and grieve many losses. Evidence-based anti-racism. How we deliver cancer care to our patients is based on studies and data that tell us what medicines and interventions lead to better outcomes, longer survivals, less toxicity. Medicine is a living, breathing, ever-changing practice. We need to approach racism in the same way, by studying healthcare institutions with fewer racial disparities and outcomes, learning what they're doing right, then modifying our practices in our institutions that are not doing as well. We can fight racism in healthcare like a recurrent gynecologic cancer, like a devastating chronic disease that is complicated and requires research and learning and honing our individual skill and knowledge to be able to deliver the best anti-racist care possible, while ever trying to improve and modify our approach so as to optimize the treatment of our patients within a flawed system, and holding ever present the dream of ultimately ending racism entirely. When we become doctors, we take the basic and sacred Hippocratic oath. First, do no harm. Everything else we do must hold up to that simple fundamental standard. Everything else we do builds from there. With respect to racism in medicine, let us start with the basic principle, first do no hate. Everything else builds from there.
Race and racism have been in existence for greater than 400 years of our country's existence. So what is the urgency? Well, we are in the middle of a global pandemic, which has disproportionately affected people of color. We're looking at COVID-19 death rates per 100,000. Indigenous people are dying at the highest rates at 168 per 100,000, with Blacks at 130 per 100,000, compared to whites of 97 per 100,000. The novel COVID-19 vaccine has the ability to change the course of this pandemic, but racism at the hands of medical professionals who have been sworn to do no harm have left many Black and Brown people feeling distrustful of our only viable remedy to this pandemic. Only if we work to make major strides in addressing racism will we be able to address the most pressing healthcare crisis of today.
Everyone today talked about bringing their research to underserved communities. And I think it was really bold to put a talk about systemic racism in healthcare under a prevention talk, right? That's not something we classically think of as prevention. But of course, if we're going to prevent these cancers in everyone, we have to look at, what's going on behind the scenes and what's really preventing our patients from getting the right care. So kudos to you and to Dr. Polit for putting that talk together. So Dr. Liu, in that vein, can you talk a little bit about what you're planning to do with the IGNITE trial, which you brought up a little bit, to broaden outreach to other folks to get their testing?
Yeah, thanks for that question. And just give me a thumbs up if you can hear me, just so I know. Okay, great. First of all, I'm just overwhelmed by how fantastic it's been to listen to these talks, and thank you to you and to Dr. Hope. I would say that the importance of talking about this is that hereditary cancer testing, whether that's for hereditary cancer or even tumor testing for treatment, it's really at kind of the tip of the spear in terms of where the field is going and incorporating kind of the newest advances. And if we can't get that to everyone, then it's not going to be meaningful. And I think that, I've been in this field for over 20 years, and it has been a challenge that we haven't been able to overcome. And so I think that, me participating in this conversation and thinking about ways to overcome it, I think there's challenges all along. If you look, we started to look at the broad topic, and, usually you start with like smaller kind of qualitative studies, just getting a group of people together and asking, why did you choose to do the testing? What were some barriers? And there's so few of those studies that are even published in Black communities or in other minority communities. So we're really starting so much farther behind. But the point of the Ignite Texas is to look and to start the question of what are the barriers, because it's such powerful information. If you come from a family where there's a lot of cancer, and we see this in minority populations where there are BRCA mutations, and if they can get that testing to their daughters and to their nieces, it can be so powerful. But we're not doing kind of what we need to really kind of get it there. But I'd be open to hearing what you think and what other panelists think about, kind of how to approach this topic as well.
Thanks, Dr. Liu. I agree. So much of what we figured out, and certainly that the NIH has identified as important, we have an idea of what the right thing to do is. It's delivery to all of our communities at risk where we fall down. And so novel delivery systems really have to be at the forefront of what we do. I think we don't have a tremendous amount of time. I want to talk a little bit to Dr. Masch. Fantastic talk. And Dr. Masch, incredible the work that you're doing, which really is getting to the heart of reducing cervical cancer in the communities at highest risk. We've got a few questions for you. One is, what about the HPV vaccine? which you talked about a little bit, but can you briefly speak a little bit more about that? Because I think some of our attendees are interested in that.
Absolutely. So HPV vaccine is called primary prevention, and primary prevention helps to stop disease before before exposure. That's when it works the best. We tend at Basic Health, we tend to focus on secondary prevention, but in conjunction with the HPV vaccine, the primary prevention, that is what is going to help eliminate this disease globally. So there is a lot of work, and we are working in concert with our colleagues who are mostly primary preventers with HPV vaccine to try and discover ways to also gain access to those same women who are at most risk, but who are in remote settings, to be able to have access to the vaccine, as well as to the secondary screening and treatment prevention measures that we discussed. There is something called Gavi, which is the Global Alliance for Vaccines and Immunizations. That is a partnership, government and philanthropy partnership that subsidizes vaccines to some of the poorest countries in the world so that they have access to vaccination, particularly of all kinds, but in my world, the cervical cancer vaccination, the HPV vaccine. So there are many people working on this effort, the World Health Organization as well, many other philanthropy organizations working to try and get the vaccine to the populations before people have sex. That's when it works the best. So there's a lot of work being done in that field too. I hope that answers that question. Yeah.
Sure, I think you did. Another question to you. One of our attendees asked that they noted that you said that cryotherapy has few long-term risks, but what are the risks associated with cryotherapy?
Actually, they're few. The risks of cryotherapy are cramping or discomfort. There is sometimes a clear liquidy discharge, vaginal discharge, that can last several days to a few weeks, but that is not thought to be infectious. It's just as the cells from the cervix slough. And then rarely there's some bleeding, but really minimal side effects. And most women find that those are acceptable. In the studies that we've done thus far, they're acceptable risks for the ability to be able to prevent cervical cancer.
Great, thanks for that. And then switching gears again, I want to make sure we get to all of our attendee questions. Dr. Liu, we had a couple of questions about the salpingectomy versus oophorectomy issue. So one, if you could clarify, one person asked if all cancers begin in the fallopian tubes, how do you distinguish the difference between ovarian and fallopian tube cancer?
Yeah, that's a great question. So right now we are quite sure that the majority of the BRCA associated high-grade serous ovarian cancers start in the fallopian tube. There are other types of ovarian cancers that are not epithelial ovarian cancers that definitely start from the ovary. So some ovarian cancers, germ cell tumors, start from a different part of the ovary. Another type of ovarian cancer are truly from the ovary. But the majority of the high-grade serous ovarian cancer, the epithelial ovarian cancers, we actually think probably do start in the fallopian tube. So the question is, why do we call it ovarian cancer? It's just because that's what it looks like, and it's kind of conventionally what we've called it. There's kind of three cancers that we all lump under ovarian cancer: fallopian tube cancer, and primary peritoneal cancer. We tend to kind of lump them all together.
Great, thank you for clarifying that. And then another question to you, Dr. Liu. If a woman has a salpingectomy, do you change your recommendation about timing for oophorectomy?
That is a great question. So in our first study, the WISP study, we really encourage women to have the salpingectomy and stick with the recommended ages to have ovaries out. So BRCA1 by age 40, BRCA2 by age 45. Our follow-up study, and actually the Dutch study, added 5 years onto that. So basically that you would have your salpingectomy, and if you're BRCA1, you could keep your ovaries until up to age 45, and for BRCA2 up to age 50. So Our follow-up study that we are really going to launch sometime this spring, and that the Dutch have already launched in Europe, is going to be together as an international group, and hopefully and kind of excitedly in partnership with Dr. Hope's group, is testing that strategy where we have a clear recommendation that if you have your tubes out, that you could kind of go another 5 years.
Great. And then briefly, Dr. Liu, when do you think you're going to get efficacy data from these trials, just roughly?
Yeah, that's a really important question. It will be 10 years. So there's a big US study that started, and they think it'll take 10 years. If we do it, we actually think it'll be 10 years. We want to kind of, we have to get started. We think it's going to take a while to get answers, but I think the key thing is that, you know, this is such an important question for women, for our pre-Vivor community, that we want to commit to, you know, to doing it and hopefully doing it more quickly. But right now we think it'll take about 10 years.
Thank you for that. And now I'm just going to open up to all of you, include particularly Dr. Hope, and I'll start to answer it a bit myself. You know, with the context of the racial justice movement, I know my medical center has really taken a look at itself, hopefully all of ours have, and has opened up a new research institute that's dedicated to disparities in outcomes research. And internally, all of our departments are kind of looking at how are our outcomes different for our patients based on self-reported gender, race, et cetera. And I wonder what changes you guys have seen in your practices now that this kind of reformation is happening.
Well, I would say that here, there hasn't been as much of a systemic response that is evident. I think that it obviously has created much more dialogue and communication, but and Alaska is a much smaller environment and a different environment. And so that's very much needed, is to start to more formally look at actually how we're doing and figuring out how to do that within the context of how healthcare is delivered here. It's a complicated combination of public health and private practice here. So I think that that's a call to action for us, is actually being able to study and look at how we're doing both you know, in the Alaska Native healthcare system, but also, and very, very importantly, in the community healthcare systems throughout the state.
And then a quick follow-up, because we just got a great new question to you, Dr. Hope. Do you think all of the good press about the COVID-19 vaccine will drive HPV vaccination efforts for Alaska Native and Indigenous populations?
Is that a question to me?
You, yes.
Yeah, well, I mean, I think actually we're the availability of the vaccine is really excellent and through the Alaska Native healthcare system. I think that one very exciting thing that we can learn from Dr. Masch's talk is the idea that using self-testing more and more as a strategy within the COVID, having COVID be sort of a push to start to do self-sampling in hard to reach settings in Alaska, that is a fantastic application. And then being able to then pair that with vaccination as well. So I hope in general that people's awareness about the importance of vaccination that's coming from the COVID pandemic will transmit to the HPV vaccine. In fact, I think we should offer the HPV vaccine along with the COVID vaccine. We could actually end cervical cancer along with COVID. So just saying it right now, that's what I think.
I like it, Joanie, I like it.
All right, it pains me to say this, but I think we are out of time. Again, I'd just like to say how proud I am to be part of this incredible group. The slides apparently are going to be available. Please read the chat to figure out how to get them. And please stay tuned. There's much more to come with this incredible lineup for today. Again, thank you all for participating. It's been an absolute pleasure.
Thank you, Dr. Boyd, Dr. Masch, Dr. Liu. Those are fantastic talks. And Leslie, I'm glad you got your computer rebooted. So we're going to go to lunch right now. And we'll be back for yoga with Margot at 12:30 Alaska time. And our third panel entitled Hope for the Cure will start at 1 p.m. Alaska time. Thank you all so much. Have a good lunch.